Hello, and thank you for joining us today for this live peer exchange on the topic of myelodysplastic syndrome, managing risk and complications. Myelodysplastic syndrome is a heterogeneous disease that necessitates an individualized treatment approach and careful monitoring in an effort to slow disease progression and prevent complications. In this live peer exchange, a panel of experts in oncology and hematology will discuss some of the challenges in managing the disease, including accurate risk stratification, complications associated with transfusion dependence, and practical considerations in the use of disease-modifying therapies and stem cell transplantation. I'm Dr. Vinod Pullarkat, and I'm Associate Professor of Hematology and Hematopoietic Cell Transplantation at the City of Hope Medical Center in Duarte, California. Participating today in our panel are Dr. Rami Komrokji, Clinical Director, Senior Member and Professor of Oncologic Sciences for the Malignant Hematology Department at the Moffitt Cancer Center in Tampa, Florida. Dr. Thomas Prebet, Assistant Director of Myeloid Malignancy Research and Associate Professor of Hematology at the Yale Cancer Center in New Haven, Connecticut. Dr. Ellen Ritchie, Associate Professor of Clinical Medicine at Weill Medical College, affiliated with New York Presbyterian Hospital, and Dr. Jamile Shammo, Associate Professor of Medicine and Pathology at Rush University Medical Center in Chicago, Illinois. Thank you all for joining us. Let's begin. First, I'll ask Dr. Shammo, could you discuss a little bit about the heterogeneity of MDS and the changes to the new WHO classification?
Absolutely. So there's been a variety of advances in the understanding of MDS biology, particularly when it comes to mutational analysis, and some recent data about the importance of identifying single versus multilineage dysplasia, which I suppose had been in the 2008 WHO classification. So it's totally not a complete overhaul of all disease entities. It's perhaps refinement of those categories. And more importantly, I think I should say that the word cytopenia has been eliminated. For example, we don't usually say refractory anemia or refractory cytopenia with multilineage dysplasia. This has been eliminated, and now you could utilize the term MDS, and then right after that, single lineage dysplasia or multilineage dysplasia, and then you identify ring sideroblast, and then whether or not it's also associated with single or multilineage dysplasia. The other thing is that this MDS also has been split into two groups: excess blast, 1, which is, as we all know, 5 to 9% blast, and then MDS excess blast 2, which is 10 to 19%. Interestingly, if you, in order to make a diagnosis of refractory anemia, I should say, rephrase that, in order to make a diagnosis of MDS ring sideroblast, you must, in the old classification at least, you must have more than 15% ring sideroblast in order to call that. But now, if you have SF3B1 mutation, which is the most common mutation in this patient population, you could have as few as 5% ring sideroblast and still be able to call this. Of course, there's always a group of MDS unclassified, which continues to be the issue, and hopefully that will get refined over time. So that's a very quick wrap-up of what the 2016 WHO means.
So does this have prognostic implications with relation to survival and risk of AML
I mean, I think when you're talking about survival and AML evolution, it's always something that's tied into other prognostic scoring system. I think generally speaking, we feel that MDS with single lineage, multilineage dysplasia, or even ring sideroblast, all those categories have less than 5% blasts in the bone marrow. And generally speaking, less than 5% blast category, irrespective of many other cytogenetic abnormalities, et cetera, which will come out through the IPSS, have a better prognosis in general. But I think, again, the WHO 2016 classification is a morphological assessment, and you need a little bit more information to kind of come up with survival and leukemia evolution. I don't know how others feel about that.
Yeah. If I may add, Jamil, so I think the nomenclature in the past system was a little bit confusing because, as you mentioned, we were talking about cytopenias, and you would say somebody refractory cytopenia with multilineage dysplasia, and they will have anemia. So every time there is discordance between what you see cytopenia and the dysplasia. And since it's, as you mentioned, a pathological classification, the naming was more geared now in the new classification to look at the dysplasia and the bone marrow. Because again, you could have refractory anemia and the patient could only have thrombocytopenia in the peripheral blood. So I think it's a little bit easier I think the other thing would be also probably mentioning the threshold to call erythroleukemias, that the suggestion to count the blasts out of the non-erythroid cells is going away, because those categories did as good as MDS rather than the true erythroleukemias. And maybe also we are starting to, again, pay back attention to the ring sideroblasts, whether they are in the setting of multilineage dysplasia or not, because now we are starting to see active therapies or clinical trials in patients with ring sideroblasts.
I'm so glad you brought up this point about erythroleukemia, because a lot of times people would get diagnosed with M6 or simply because the percentage of blast is greater than 20% in the non-erythroid, where now you look at it as a whole, which I think we will have a lot more MDS cases in this situation. So.
But we still need to give a lot of credit to the pathologists, because it's still most of the more challenging diagnoses to make.
Absolutely.
And that's one point that is maybe a little bit more easy now with the WHO 2016 classification to see exactly where we are, but it's still a pretty challenging diagnosis.
So, Rami, you brought up this issue of treatment modification. Does this new classification has any implications for treatment?
Right, so that's a good question. I think in the erythroleukemia it may, because some of those patients in the past were automatically looked at as acute myeloid leukemia and could have, probably received induction chemotherapy. There is some experience that had been already available and published that those patients do pretty well on hypomethylating agents, actually probably even better than MDS. So I think now we are going to start looking at those, as Jamile was mentioning, as MDS. I think what happened with the prior version of the WHO, that if you had multilineage dysplasia, those patients did not do well. So the refractory cytopenia with multilineage dysplasia and ring sideroblasts got collapsed into that group. And we started calling them all RCMDs. We did not pay attention much to the ring sideroblasts. Now we are trying to find, we are finding that that subset of ring sideroblast patients are a little bit unique. There are some available treatment options for them, and in fact there are clinical trials, in phase 3 targeting that population. We are talking about the mutation that Jamile mentioned, the SF3B1, that's particular in that population, and now the splicing inhibitors are going in trials. So I think we are going to pay attention to the ring sideroblast among those categories. Those are the initial thoughts on how the therapy will be based on this classification.
So for all ring sideroblasts, all the MDS with ring sideroblasts are not the same. That's what you're saying.
Right.
And there may be a prognostic implication for that.